Welcome to the Emory Department of Emergency Medicine Ultrasound Image of the Week podcast. I am Karim, Emory EM Administrative and Ultrasound Fellow. This week's Image of the Week goes to Dr. Todd Taylor. Dr. Taylor does an excellent job of demonstrating how to diagnose pneumothorax using ultrasound. Ultrasound is an excellent imaging modality for lung pathology, especially pneumothorax. To get started, place the linear probe on the patient's chest in the second intercostal space, oriented longitudinally with the probe marker pointing to the patient's head. On ultrasound, bony structures, notably ribs, appear hyperechoic or bright and have shadowing posterior. Pleura is seen as a hyperechoic straight line extending between two rib shadows. Optimal screen depth allows for two ribs to flank the screen, with pleura between and the pleural line centered in the image. One of the basic premises of lung sonography is the concept of lung sliding. It represents a layer of visceral pleura sliding on parietal pleura, lubricated by a small amount of pleural fluid. During breathing, spontaneous or mechanical, lung expansion creates a sliding movement between layers of pleura. Ultrasound cannot identify a specific pleural layer. However, lung sliding is simply noted as a shimmering motion of the pleura with respiration. Normal, healthy lung without pleural injury will exhibit pleural sliding. Clear identification of lung sliding excludes pneumothorax at that specific location. Now contrast this with the images obtained by Dr. Taylor. His patient presented with trauma, and on ultrasound, no lung sliding was evident. With respiration, no movement is noted at the pleural interface. M mode may also be used to diagnose pneumothorax by simply pressing the button labeled M mode on most ultrasound machines. M mode, which stands for motion mode, is a still representation of a single vertical line of echoes from the B mode image. On the M mode image, the x-axis represents changes in the echoes or motion with time. Each layer of the M mode image corresponds to a layer in the still image above. M mode then represents how tissue layers change in their motion with time. No significant change is expected in any soft tissue layer with respiration. However, pleural movement and sliding results in motion artifact on M mode and appears different than soft tissue. As noted in this video, the soft tissue representation does not change with time, but the pleural sliding is represented with motion changes, known as the seashore sign. Sand, soft tissue, is stationary, but the water, pleura, is in motion and appears different than the soft tissue above. Contrast this again with the video obtained in M mode by Dr. Taylor. His patient with a traumatic pneumothorax has no sliding motion at the pleural interface. Therefore, the M mode image appears static, and there's no difference in the appearance of the soft tissue layers as compared with the pleural interface. This is sometimes referred to as the stratosphere sign, given its stillness, or the barcode sign. In a prospective, single-blinded study of blunt trauma patients at a level 1 trauma center, Blevis, Lyon, and Dougal demonstrate the effective use of ultrasonography in the detection of traumatic pneumothorax. 176 patients were enrolled in the study, with gold standard for pneumothorax detection being CT chest. The sensitivity of chest radiography was 75.5%, and the specificity was 100%, while the sensitivity of ultrasound was much higher at 98.1%, with comparable specificity at 99.2%. To wrap this up, let's summarize this podcast. Take-home point number 1, ultrasound is highly sensitive for detecting pneumothorax, much more so than chest x-ray. Take-home point number 2, pneumothorax can be seen on B mode by absent pleural sliding. Last, take-home point number 3, pneumothorax can be picked on M mode by a lack of motion artifact, known as the barcode or stratosphere sign. That's it. Thanks for watching. See you next week.